Right, we'll make a start, everybody. Thank you very much for coming along. My name's Manny. I'm the practice manager for the football clinic, and tonight, as you all know, we're doing our second session on football injuries, and tonight's session will be focusing on hamstring injuries. So I'll just quickly flick through the agenda. So we've got the main presentations from the team, and we will top and tail it with a few words from myself on the clinic. And then at the end of the presentations, Andy, the general manager here at MIHP, will say a few words about the facilities available here. There's also a tour available at the end, and then there'll be the food and drinks as well. Also mention, if anybody hasn't already, please feel free to pick up a bottle of water from over there if you need one. Right, so the football clinic, I won't be going through everything on here, so this is a bit of a shameless plug, so I won't go through everything, but there's a couple of things that I wanted to just say about the football clinic. The first one is a free advice service that we provide to any professionals. What we found is that what works really well is setting up some kind of group chat facility, whether that's WhatsApp or anything else. That works really well as a way for any of you to get in touch, ask any questions, and we can sort of all chip in with our opinions. So that tends to work well. And the other one is the second opinion service that we offer. Where that's particularly useful is if there's unusual cases, and again, you're looking for advice. So again, getting in touch, that can really work well. But as you can see, I mean, there's a full breadth of different services that are available via the football clinic. We're obviously based here at MIHP, so we get to leverage all the facilities that are here as well, which I'm sure Andy will say a few words on at the end. Just a few other things. We will be recording tonight's session, and we'll be starting that shortly, I believe, Molly. And we'll also be issuing CPD certificates to everybody who attends. And again, Molly will be doing that in the next day or so. Okay, so I think without further ado, I will hand over to Gulraiz, who will start the presentations.
Brilliant. Okay, guys, so today's first session is on the applied anatomy of the hamstring complex. So as we all know, there are three main hamstring muscles. We have the semimembranosus and semitendinosus, which insert medially, and then the long head and short head of the biceps femoris, which insert laterally. It's also worth mentioning that the adductor magnus has a hamstring component and originates from the ischial tuberosity as well. Collectively, these muscles extend the hip and flex the knee joint. So we'll start off by looking at the hamstrings from a proximal point of view. So the semimembranosus tendon originates from the superlateral ischial tuberosity and is the larger of the two proximal hamstring tendons. The semitendinosus and biceps femoris, the long head of biceps femoris, arise from the conjoint tendon, which is almost half the size of the semimembranosus tendon. And this arises more along the inframedial aspect of the ischial tuberosity. The short head of the biceps femoris arises from the posterior femur, the linea aspera. So this is an actual image through the actual proximal thigh. We see that the semimembranosus tendon arises laterally, and then the conjoint tendon is medially attached. If we then break down the proximal hamstrings into two separate units, we see that the proximal semimembranosus tendon is a large, wide tendon, and then the muscle belly and the muscular tendinous junction arises along its medial aspect. If we then look at the axial images through the proximal thigh, what you tend to see is that the lateral aspect of the actual semimembranosus tendon has a very thickened cord-like appearance, and it flattens out more medially, giving the characteristic tadpole appearance. As we go more distally, what you then tend to find is that the semimembranosus muscle belly begins to form, and this becomes initially as a triangular shaped and then becomes bigger as you go distally. If we then look at the conjoint tendon, the first muscle belly that comes off the conjoint tendon is the semitendinosus muscle belly, followed by the biceps femoris, the long head of biceps femoris. We then go through axial images through the actual proximal thigh. Again, the first tendon that we see, the first muscle belly that comes off the actual conjoint tendon is the semitendinosus muscle belly. As we then go further distally, the biceps femoris begins to form along the lateral aspect of the conjoint tendon, with the semitendinosus coming off medially. And then further go, that's another distal image for that. So now if we summarize the proximal hamstrings, again, looking at it from a proximal point of view, you see the semimembranosus arising from the ischiotubrosus along the superlateral aspect, and then the conjoint tendon coming off more medially, giving the semitendinosus and biceps femoris. If we then insert the sciatic nerve into the picture, which lies deep to the biceps femoris, we can then look at it in cross-section, and this is a very useful landmark to look at when you're looking at the proximal thigh, both in ultrasound and MRI examination. There is a point where has a very characteristic trident shape, which can look a bit like a Mercedes-Benz sign. So it's something just to be aware of. And I don't know whether some of yourselves do ultrasound, but when you're scrolling through the proximal thigh, you can sometimes find that appearance where the sciatic nerve has an echo bright appearance, and then you've got the conjoint tendon and the semimembranosus tendon giving that characteristic Mercedes-Benz sign. If we then go more distally, what we tend to see is that the distal semimembranosus muscle belly has a large muscle belly, and it has complex bony and capsular insertions which insert into the posterior aspect of the knee joint, and they form part of the posteromedial complex alongside the other structures such as the posterior oblique and the oblique popliteal ligaments. The semitendinosus distally has two muscle bellies, and again, one point to realize about the actual semitendinosus is that it's a digastric muscle, i.e. it has two muscle bellies which are separated by a central oblique fascial band known as the raphe. And this is an important landmark to be aware of, or important structure to be aware of, because it's a site where tendon tears can occur. Distally, the semitendinosus has a thinner appearance, and often when you scroll down the MRI thigh more distally, you tend to see that the appearance of the semitendinosus is that of a cherry on a cupcake, the cupcake being the slightly bigger semimembranosus muscle belly. And they finally insert onto the anteromedial tibia, that's the semitendinosus tendon, alongside the other pes anserine tendons. So if we then look at the biceps femoris distally, the biceps femoris alongside the lateral collateral ligament forms a conjoint tendon which inserts onto the fibular head. One thing that's important to be aware of, and this we'll talk about later on with the muscular calcification and injuries of the hamstring tendons, is to be aware of the complex muscular tendinous T-junction. Now this just forms proximal to the actual insertion of the actual tendon itself. And the T-junction is actually formed by the convergence of the short and long heads of the biceps femoris. So the proximal aspect of it is actually formed by the anterolateral epimysial surface of the long head of the biceps femoris. It's almost like an aponeurotic fascia that sort of envelops and forms more distally with the posterolateral epimysial surface of the short head of the biceps femoris. And then distally, it's the posterolateral epimysial surface of the short head which forms the T-junction. Now, the reason why this is important is that this is often a site where you can get these particularly difficult tendon tears to treat, and Prof will talk later on a bit more about the types of tears that we tend to see. So in summary, we've talked about the proximal hamstrings, the fact that there are three main muscles and that they originate from two tendons. We've also covered the Mercedes-Benz sign, and as well as looking at the distal muscular tendinous T-junction. Any questions on that so far? Yeah.
My name's Neil, I'm an orthopaedic surgeon. This is probably the easiest talk I'll ever give because it's pretty obvious, isn't it, when to operate, when not to operate, and usually when not to operate. So what we do, oh, I've gone back, haven't I? Gone the wrong way. Brilliant. and operate this stick. So we've heard about anatomy and diagnosis. So let's just go straight to surgery, shall we? Or not, as the case may be. And the reason is because it's pretty obvious, isn't it? If we see someone like this, we know what's wrong. If a muscle has come off bone, it's probably not going to work very well. So it makes sense to reattach to bone. But just a rough guess, and the winner or closest to the mark will get a free bottle of water. How much power would you lose if you rupture your proximal hamstrings? Yeah, go on. How much power? Give us a percentage.
So a friend of mine, you probably want one answer here, don't you? But a friend of mine ruptured one of his hamstring tendons. I think it was semimembranosus, about 2 years ago. He honestly, in the gym, he lost about 15-20% power, and then maybe not even that. So he actually didn't get properly diagnosed with it until about 8-10 months down the line. Yeah. So he was, and then it was, oh, it's actually reattached further down. So he didn't really notice it, but presumably it, I mean, it didn't, I don't think it looked like that when it did. So
You'd hope not if it was missed. So it's said up to 50% loss in absolute power, up to. So it could be 50, could be less. And that's absolute power, repeated power, but also crucially in explosive sports like football, the rate of muscle contraction as well. So people will notice a difference in the highest level of professional sport where power is involved. The obvious things are the avulsions, as we've talked about. If proximal hamstring pulls off, we should reattach it. If the distal hamstring pulls off the fibula, biceps, we should reattach it. That's pretty obvious. And the reasons are clear to see. You can return to play at the same amount of time, but you get a better function and a reduced risk of re-injury for these avulsions. There's a much higher patient satisfaction and a much higher, better strength from them. So that's undoubted. So why am I even talking about this? This is so obvious. It's because there's some not so obvious potential in implications or reasons to operate as well. And they'd be musculotendinous tears, chronic tears, or partial tears. What do we do for these patients who, generally speaking, we don't know necessarily what to do if we're down the line with it? Classifications can sometimes help organise our mind and help plan what we might do in terms of management. There's two really good classification systems. Wood classification, this is named after and invented by David Wood, probably the guy in the world who's got the most experience with proximal hamstring ruptures. He's an Australian surgeon who's getting towards retirement now, but he's done thousands of these and has a phenomenal wealth of experience with them. So he used that wealth of experience to create a classification system based on it. And then I'm sure we're all familiar with the British Athletics Muscle Injury Classification Score, which we can apply to any injury. So we'll just touch on those. So the Wood classification, type 1, seen in adolescents or skeletally immature people generally, it's an osseous avulsion. So skeletally immature, the weakness isn't at the tendon bone interface, the weakness is in the bone because the tendon bone interface is very, very strong. So it's an avulsion of bone. Type 2 is a musculotendinous junction injury, which we'll touch on a bit more later. Type 3, incomplete avulsion or a so-called partial tear. Type 4, complete tear with very little retraction. And type 5, a complete tear with a lot of retraction with or without sciatic nerve involvement. Type 5B with the sciatic nerve involvement, you might see described as type 6 in some descriptions. And some caveats to that. Type 1 would seem very obvious to take the bone, reattach that, screw it in place, bone on bone healing, that's going to do very well. But in actual fact, those patients have real trouble sitting down. Prominence of metalwork is a real issue for them, and you have to go back and remove that metalwork, which is quite difficult to do in what has become a very scarred up area. So actually, there's a thought process to actually excise the bony fragment and reattach the tendon to the bone in those patients. Type 2, in a high-grade athlete, it may actually warrant a repair to decrease the rate of recurrence. We'll go on to that. Type 3, the partial tear, if they present late and non-operative treatment hasn't worked, then surgery is an option for those patients. Type 4, the avulsion without a lot of retraction. Operative intervention seems to have improvement in functional outcome when compared with non-operative. And type 5, as we've seen, it's obvious in the elite athlete. And type 6, for us as surgeons, we have to think about the nerve, because you might reattach the tendon, but if you damage the nerve, that's a big problem. So they require formal identification of the sciatic nerve and neurolysis of it along its length. Just for revision, really, more than anything, this is the BAMIC classification, which we're all familiar with. And we can kind of adapt some of those principles from the Wood classification and what we would do surgically to this as well when thinking about it specifically to hamstrings. So a bit more about those not so obvious ones. Why might we ever think about operating on the myotendinous junction? Well, these patients who have a myotendinous junction injury have a longer recovery and an increased recurrence when compared with a lower grade injury. And the reason is because tendon healing and remodeling takes longer than muscle healing and muscle remodeling. And the reason is that it's got less vascularity. We all know that, we've all seen that. Cadaveric workshops can show it, and what have you. You know, we've got the tendon that has no blood vessels really in it compared with the muscle. Other factors are that we might mismanage them. We might consider it, well, they're doing all right, it's a muscular tendinous injury, but, you know, we might get them back a bit quicker. Don't sit on your hands, give it the full time, see it through, see the rehab through, and don't cut it short, because if you do bring them back too soon, you can reset the clock, you get that recurrence and enter into a vicious cycle of repeated injury. And then once you get scar tissue, you can get an excessive scar tissue. And this is a problem where you end up with effectively a stress riser. So you've got tendon, you've got scar tissue, you've got muscle. And where you get differences in tensile strength of tissue, you get weakness. And you've got two or three potential interfaces there: muscle, scar, tendon. And so there's now more than one area where you can get a recurrent tear. So that's a problem. And it's said that there's up to 57% of recurrence in distal biceps myotendinous junction injuries, including the T junction that I'm sure Prof will talk about in a bit. The principles of surgery, because people often ask you, well, what do you actually do? You know, you can't really operate on a muscle, and you can't operate on a muscle. But what you can do is remove any scar tissue that you see. So you can excise that scar tissue and repair a defect through the fascial layer. The idea being that you're creating more of a uniform repair, really, to create an equilibrium of tension to spread any stress across that repair. The idea being then that you get a more uniform response and a uniform healing, and less likely a recurrence, and less differences in extremes of difference in those stress rises. And in terms of case series, there are some good results. In terms of proximal myotendinous junction injuries, a paper of 41 high-level athletes, high-grade injuries, all returned to their pre-injury level between 8 and 18 weeks after surgery, with a 5% re-injury rate. And in the distal side, it was much better. 34 professional athletes, 100% returned to full activity, but this paper only followed them up at 1 year. What about the chronic tears? Is that possible to do? Well, a chronic tear, particularly an avulsion, if not retracted, it's very easy to address surgically. If there's only been a centimetre of gap, that fills with fibrotic tissue, which may not actually be functioning tissue. It's just filling the space. So it's effectively like a maintained avulsion. It's very easy to go in, excise that, cut back to stable tissue or stable tendon, and attach that back to bone. Where it becomes a lot more difficult is with the retraction. Like any muscle, if it's retracted, if it's pulled off and it's chronic, it's a long period of time, the muscle still wants to be, well, the muscle's still innervated, it still wants to contract, and each time it's pulling that tendon further and further away from where it should be until it settles down somewhere, scars down, and then you've got a big problem, because when you go in, you've got to free up that scar tissue. It's a higher risk of complication because it's most likely going to be adherent to the sciatic nerve, which is difficult to free up. And then there's a higher risk of failure of the operation to be performed, and then failure to achieve your outcomes. It's harder to reduce a retracted tendon. There's less elasticity in the musculotendinous complex, so you might not be able to get the tendon back to bone. It is possible to use an interposition allograft, something like a donated Achilles tendon, to bridge that gap. But even then, you're not going to get the same power, the same strength in that muscle group, because you've stretched it over a longer working length. So your tension within the muscle won't work as powerfully. about the partial tear? Well, traditionally, these are managed non-operatively initially, and still many of them do very well. So we reserve surgery for the failure of non-operative treatment. One study showed 48 patients with a partial tear. 18 were unable to return to play after non-operative treatment, and of those, 87% were able to return by 5 months after the surgery. As shown here, it's now with modern techniques of reattachment, it's a very reproducible procedure. So why not operate on everyone? I say I'm obviously very biased towards this end of the spectrum, and ultimately because it's not really required, is it? I mean, we've all treated patients with hamstring injuries. You guys will have treated a lot more than me, because I only will see the tip of an iceberg of them. And I think we'd all agree you best treat non-operatively, because surgery isn't always required. In at least 87% of cases, you can treat very well with non-operative treatment. And let's be honest, surgery is not without complication. And if we're being brutally honest with ourselves as surgeons, 1 in 5 people has a complication of hamstrings surgery, whether that be neuropraxia, irritable scar, or worse still, a sciatic nerve injury. There's also a relatively high rate of infection with the hamstrings surgery, particularly proximal hamstrings, as you'd expect because of the proximity of the gastrointestinal tract. But if you look objectively at non-operative treatment, recurrence is quite variable in the literature. It's as low as 14%, it's as high as 63%. So it'd be nice to know what factors affect that rate of recurrence. Well, we know grade of injury affects recurrence. The higher the grade, the more likely it is to recur. The site, if there's involvement of the central or proximal tendon, is more likely to have a recurrence. If it's the biceps femoris, it's more likely to have recurrence than semi-T or semimembranosus. If there's a loss of active knee extension, if there's localized tenderness after return to play, or if there's a premature return to play, these also affect recurrence. In terms of premature return to play, we know in low-grade injuries, we can get a return to play 2-3 weeks. Recurrence rate very low, but significantly different in a high-grade injury. The initial reparative phase of healing forms this functioning limiting scar. And if you think about that, the scar will take at least 6 weeks to start to form. And then once it's formed, it needs to undergo the remodeling phase. This is just normal biology. So to complete that remodeling phase will take a lot longer than 6 weeks. And so the return to play is thought to be in excess of 50 days for this. Returning before carries with it risk. And then finally, just about the timing of the surgery. We know if you operate soon, you've got an association with less complication and a quicker return to play. Surgery within 8 weeks of an injury, an acute injury, is associated with a reduced sciatic nerve injury by half. And a delayed repair, if you do a repair after 6 months, the average return to play was 29 weeks as compared with 16 weeks if an acute return to acute surgery. So if we were to put all this together and summarize some take-home messages, without a doubt, most hamstring injuries will be treated non-operatively. But if they're not treated well and you cheat the biology, particularly in high-grade injuries, you do run the risk of recurrence. And if they get recurrence and more recurrence and more recurrence, then they may well end up needing surgery. Now, if they do have surgery, we know proximal or distal avulsions do very, very well with surgery. But we still need a prompt diagnosis. If you can do surgery within 4 weeks, the risks are even less than what we've shown you from 8 weeks. And for recurrent myotendinous injuries, surgery will remain an option. So, thanks very much. And
do you ever use dynamic ultrasound to help with decision making for surgery after a return? If so, when? And players with.
Should we do that one first? Yeah. Okay, so the answer effectively be no, not really. I mean, I'm very lucky and very privileged that I get to work with not just one but 2 fantastic radiologists here. So we generally get an MRI scan and chat it through in the MDT. Waqar, myself, Gulraiz, and Steve, and I don't know, being able to bounce ideas off 3 fantastic colleagues. It's probably better than a dynamic ultrasound for me, but I don't know.
Sometimes just follow tender repairs rather than primary diagnostic.
The second one, players with hematomas post-tear, when would you consider aspiration?
I can answer that.
That's a good question, isn't it? Yeah. Oh, I think there might be a slide on that later. So I don't want to.
Just repeat the question.
Sorry, yeah. So question from, what's your name, mate? Question from David. Do distal repairs fare differently to proximal repairs? Yeah, I do, actually. I can't prove it, but anecdotally, I think distal repairs probably do a little bit better, to be honest. Yeah, in my hands. You know, maybe contrasting to the literature, but yeah. Sort of, I mean, conventionally, yeah, I'd agree with you, because it's that kind of, there's not a lot of evidence about it. When we're taught in orthopaedic school, if you like, it's just avulsions that you operate on. What are you even thinking of operating on a muscular tendinous junction? That's ridiculous. But you've got to credit the likes of Faraz Haddad in London, who does the procedures and gets data from it and then shares it amongst the community. And you know, his work has been fantastic on hamstrings in this country for sure. Brilliant. Thank you.
Could you repeat the question for the guys on the?
Do we use MRI and ultrasound for tissue healing? What we tend to use is MRI for tissue healing rather than ultrasound, unless there's a tendon injury and the attending surgeon wants us to monitor that tendon or to assess it and stress that tendon. Remember, going to stress that tendon probably 6 weeks into the healing process, not at the beginning, because we want to do no harm to the patient firstly. So our way of monitoring really is MR. Why? Because we're comparing like with like, and it's reproducible, and those MR images can be sent throughout the country or throughout the world for them to view, and there's no ambiguity. They compare one to another, and ideally do the same sequence at the same hospital if you want to compare like with like. So I'd say MR scan for comparing. Again, it's all down to the budget of the club. We're quite fortunate. We've got 2 good teams, one better than the other here, unfortunately. But that's why I would suggest. But of course, you can use ultrasound as well, but the spatial resolution of ultrasound is not as good as MR, unfortunately.
Right, over to you, Steve.
So yeah, hoping up to this point. Right, so this should have been at the start of the evening, so apologies, but hopefully it'll still be of value. So yeah, probably start with one of the most heart-sinking moments of 7 seconds into a game when someone's hamstring goes and end up phoning Lee to tell them the news of what's going on with the player. But just an example of the multifactorial nature of a hamstring injury. You can't put that one down to fatigue, you can't put it down to numerous factors, but the injury going after sort of 7 seconds of a game just sort of highlights how we need to have a real open mind and take everything into consideration when we look at these injuries. Okay, so again, some of these facts have come up, so hopefully we won't spend too much time on these. We'll whiz through this, but we know that it's going to be between 12 to 15% of all the injuries we're going to see are going to be hamstring injuries. So usually about 7 players in a squad of 25 are going to get a hamstring injury over a season. So we know we're going to see a lot of these. And then there's sort of extra, and it's 37% of all muscle injuries. So the question we've got to ask really is, what's the trend? And this is slightly out of date, so we only got to 2014, but there's an annual increase of over 4% from 2001 to 2014. So for some reason, we're still getting these injuries, and we haven't, as a sort of industry, found a way of sort of blunting that sort of spike. And then when we look at that, we know that the prevalence in training is about 9% of all injuries, and about 0.51 per 1,000 hours, sort of the incidence of injury. But the burden in training is only 6 days per 1,000 hours. So we can see that the prevalence in matches is higher, and then the injury rate is significantly higher, and that burden is going to be higher. So we can obviously see there's something to do with intent and intensity of that match play that's going to make the injuries 9 times more likely to happen than in training, and then 14 times the burden is going to be increased. Recurrence we've already touched upon, so up to 63% of these can reoccur, and within that first month is the highest risk in that, and remains significantly high for 12 months. When you listen to the Australian group of sort of Opar and Timmins, they talk about that anything return within 2 weeks, even these minor injuries, there's a real high recurrence of injury. And their sort of suggestion is that those who've had more high-speed running exposure in their rehab have got a less likelihood of reoccurrence. So we know if we give them some time and we give them that high-speed exposure, that recurrence rate is going to be less, but still going to happen. We've already talked about biceps fem as the highest recurrence rate. And if you've had a previously injured hamstring, you're more likely that's going to get injured in the future than a non-injured hamstring. So back to that original question, why is that trend still going up? And why are we seeing this increase in hamstring injuries? This brings me back to one of my worst moments in a presentation of presenting to Roy Keane and Brian Robson in the front row, where I told them that the game is faster than it had ever been in their day. They did more high intensity running, and there's lots of stats from GPS to confirm that. And they both looked at each other and said, "That's not true." So you're like, okay. So we know that the game's got quicker, it's faster. The total distance hasn't changed hugely in that 2006 to 2013. This is Chris Barnes's work early on in the Premier League, but we know that high intensity running has increased significantly, and the sprints are shorter, but they're more explosive and they're more frequent. So we know that if we're talking about hamstrings, and again from the Timmins group, they talk about it takes about 60% motor unit recruitment of a hamstring to run to about 80% of your max speed. But then when you go to that 90-95, it's going to take about 90-95%. So there's a big increase from just high speed running and pitting sort of max speed running. So we need to understand that the players getting more exposed to that top speed of running. So they need to be capable, physically capable to cope with those demands. So yeah, so if we summed up in one statement, why are we getting these injuries? The tissue's unable to tolerate the load that's being placed under, I think. If we were just trying to get it into one word, I think. And this is from sort of, I think my son's sort of GCSE textbook at looking at what happens to force and length over sort of a child's development. So if you're doing nothing, you've got this steady development of length and force. If you have a flexibility training program, that increases the range. But the only thing that's going to increase that force and the length is going to be resistance training. So I think we all know that, but I think it shouldn't be underestimated. And then looking at this sort of simple just box chart on the right hand side, at the bottom we've got low sprinting and high sprinting, and on the other axis we've got weak hamstrings and strong hamstrings. So if we've got an athlete who has a low sprinting demand, they can probably get away with having weaker hamstrings, for instance. So a goalkeeper might be one example. If they've got a high sprinting demand and weak hamstrings, that's that sort of box of doom. We don't want those athletes in there where the role within the team is lots of sprinting and we know they've got weak hamstring capability. What we want to do is get everyone up into that top corner where they may have high sprinting capabilities, but they've got strong hamstrings to cope with it. And this is data taken from sort of some of our teams of where they're sort of profiled. So we've looked at their sprinting outputs in games, and then we've looked at their strength of hamstrings just with a simple sort of Nordic exercise. And what we're trying to do is shift them across into that area. And this probably explains why sometimes just because you have weak hamstrings doesn't mean that you're going to be injured immediately. You puts you in that higher risk group, but then it just depends on your exposure. So if you have a player who has high sprinting demands and has that weak hamstring, they're the ones that you need to convince that it's going to be the compound effect of them playing, which might lead to the hamstring injury. It doesn't mean they're going to get injured next week, but either the next month or the next season, they're putting themselves in a higher risk. So again, back to the question of why are we still getting these injuries? We've got some really strong evidence base for eccentric training. So when we're talking about fascicle length, if we can eccentrically train these muscles to get them stronger in outer range, change that fascicle length to make it longer, in theory, that's going to make them more robust to handle those eccentric contractions in football of high speed running. And in theory, they should be able to tolerate that more. And there's strong sort of randomized controlled trials which have shown this from Van der Voor's work and Peterson's work, which was the earlier study in Denmark. But we've still got this trend. So if we've got this evidence base behind us, why are we still getting these injuries in sort of professional elite football? And I think it becomes really clear when you start to dig deeper into the papers. So when you look at the Peterson paper, I'll just put that slide up there, that's the recommended exposure to sort of eccentric Nordics that they were suggesting in the paper. So at week 10, they should be doing 3 sets. Sorry, week 5 to 10, 3 times a week, they should be doing 3 sets of between 10, 12, 10 and 8 Nordics, which anyone in the room with a fixture calendar of games on midweek and Saturday and midweek, it's impossible to get that in. So what happened, I think, is the evidence base was out there, but it wasn't actually applicable to elite sport. Whereas now there's been more work done from the Timmins group. Once you can get this exposure in pre-season, to get some of that basic strength in, you can actually have a top-up dose of sort of 2 sets of 4, let's say once a week is probably enough to sort of maintain. Whoa, Yeah. Don't think it's touched anything now. What was that? Is that better? Win? Sorted it? Right. So just briefly going into the assessment. So I think the most important thing is the subjective history before we go into some of the objective assessment, which fits in with exactly what the prof was saying when we're looking at the scans. How much information can you get? One of the 2Cs that I was sort of alluding to is the mechanism of injury was a short stabbing sort of concentric contraction, and imaging suggesting it's a 2C injury, but then the player feels fine, he's got good strength, he's hitting all this sort of data, and he's keen to sort of sprint, and he can actually sprint. And the rehabilitation focus ended up being on all the concentric actions because it was a concentric mechanism. So I think we've got to make sure we get as much information as we can from the video, from the patient, to understand how then we're going to focus the rehabilitation. Most of these slides are taken from the Aspetar sort of hamstring protocol group, which, if you haven't seen, is really an sort of amazing piece of work with some solid research, and they've gone through all these various factors, and they've got supporting factors for how accurate these sort of assessment techniques are. So it's free to access and it's available, but this is their sort of assessment card which they follow with all their patients who've come through their clinic. And the main ones they've found are most reliable on sort of supporting that return to play is the average pain. So asking the player the VAS score every day and monitoring that. The total length palpation. So it's taking the time to actually mark it out with a marker, the length of that palpation, and palpating that daily and having a good monitor of that, because it does reduce in size. And that's a good indication that we're going the right way with the rehab. Again, the outer range strength. So a handheld dynamometer in outer range, I think, is if you can, is a must really to have that sort of information that you can be monitoring on a day-to-day basis. If you haven't got that sort of testing, even just up on the shoulder, you know, single leg sort of bridge, getting them to push through, is the athlete confident to bridge single leg on your shoulder and lift the backside off the bed? Those who aren't, you know, you're going to have a significant sort of injury there or significant progression before they're going to be ready to go to the later stages of rehab. So handheld is better, but there are ways you can sort of mimic that to get an idea of how willing the athlete is to put strength through that muscle in a lengthened position. And then MIHP, which we'll go to on the next slide. So we'll look at the maximal hip flexion, active knee extension. So athlete lying in supine, pulling their knee to their chest and actively measuring that range of movement, which is another really accurate one of progression. So looking at left to right, or if you've got any pre-injury levels, will give you a strong indication when that range has come back through. So you can see there on the sheet, I haven't circled all of them. That's probably my preference and bias. If you were looking for 3 or 4 sort of key assessment aspects to monitor that injury, I think these ones would be key there. Okay. So going through those tests there, so just using the goniometer, so looking at that passive straight leg raise, so giving you that willingness of the patient to get to sort of R1 and sort of R2. So we're monitoring that, we're getting a feel for the tissue there. The central one is that maximal hip flexion, active knee extension. So again, the patient actively going into that range, how confident are they to go in there, and you can get an accurate measurement left to right. And then pain-free passive knee extension. So again, there's an active component and a passive component. And that's probably, if you're going to pick one, the one of choice. If you're struggling for time and you want to just do 1 or 2 things every day to have that sort of objective assessment on a day-to-day basis. And then on the strength testing, which we mentioned before, you can see the eccentric outer range closest to me. So looking onto the shoulder, putting through there. You've got the mid-range test and then sort of inner range test. Again, I don't think you need to do all of them. And I think at the start, you're going to work it to make, so the athlete's going to push into you. And as they get more confident, you can then try and break the athlete. So you can get a more maximal contraction, comparing those left to right. Just touching on there, one example which isn't there would be this sort of Askelin's work. So Askelin's apprehension test. So I don't know if you've seen that, where he puts a brace on the knee and then rapidly sort of goes into an active straight leg raise. That's looking at sort of recurrence rates. Those who passed that had a lower recurrence rate than those who didn't pass that. So another test latest in rehabilitation, which is worth considering. An area which I won't go into too much detail because it's also another presentation in a sense, is that sort of movement assessment. So we've gone through the subjective history, we've got an understanding of the length of the tissue, we've got an understanding of the strength of the tissue. But when we look at the source systems pathology, so the source of the pain, so is that a tendinopathy, is it a hamstring strain, is it a femoral acetabular impingement? This is really useful to the radiologist and to the surgeon, but isn't really useful to us as clinicians because it doesn't really give us an idea of what's caused that. So when we want to assess these patients, we also want to look at their movement dysfunction. So are there any other things which are going on which we might be able to assist in the rehabilitation? So examples in the hamstrings is looking at that give into lumbar flexion. Have they got a increased stiffness in their hamstring, which they're having to give into sort of lumbar flexion to get their range in their hamstring? Is that then going to lead to sort of neurological and sort of neural issues, which might then have an impact on the injury? So understanding how strong they are sort of in their core and what impact that's having when they lengthen the hamstring around the lumbar pelvic region. Similarly, when you look into that give into extension, so you do a prone knee bend and you're bending the knee into full knee flexion, what happens at the lumbar spine? Are they able to maintain that, or have they got really tight anterior structures which causes them to give into extension? You're looking at line B, you can see that they're in a position where they're in hip flexion, so the hamstring's then going to have to be dominant to try and assist in sort of hip extension rather than hip extension and hip extension and knee flexion. So these are things understand that if we're stiff in this lumbar region and we give into extension, as the hamstring lengthens, they're really tight in here, the hamstring's going to be under increased tension. So this becomes a part of the assessment as well, that we're not just going into the strength of the hamstring, even though I've definitely got a bias that we need to get these tissues physically capable to cope with the demands of professional football. And again, we know that length, if the muscle is shortened, so in the example of the give into hip extension, it's going to be shortened because it's going to try and assist that hip extension. So we've got inactive glutes. And then we may have the example of the hamstring being lengthened as well, so it's stronger in that outer range. So we're looking to assess that as well. So we're just going over the sort of fundamentals of the rehab and return to play. So the principles of rehabilitation, I think, if you put into two simple statements for me, would be reduce the load that's going through the structure, which is alluding to what I was just talking about on that assessment of that movement sort of structures, which we'll touch upon, and then increase the load which it can tolerate. So can it cope with the physical demands that you're placing it under? So that's position specific and sport specific. So on that first example, so reduce the load that's going through the structure. Can we reduce the biomechanical load, which it can't tolerate? So in the example of a knee, I think we're all understanding that biomechanically, if a knee's got a knee valgus, if we can address those biomechanical sort of insufficiencies, then we know that we're going to put less stress through the lateral compartment of the knee. So I think that's really easy to understand in the knee, but it's exactly the same for the hamstring. So we were just touching upon that there. So if the structures going through the hamstring biomechanically are at a disadvantage due to lumbar pelvic control, if we can address that within the rehab, then that's going to reduce the loads going through those structures. So I think that sometimes we overlook that with all the great evidence we've got for sort of strength training and fascicle length and eccentric loading. I think as physios and specialties who are looking in movement and movement control, I think it's something that's overlooked. It's just really difficult to quantify, isn't it? We can get numbers from a Nord board. It's difficult to quantify the movement, but something I think we shouldn't be overlooking at all. So increasing the load which it can tolerate. So increase the capacity of that structure to tolerate those demands in the competition, which we've touched upon. So this is going into sort of strength and conditioning, sort of muscle physiology. So the ability of a muscle to resist strength is determined by these things. So it's that force production capability, it's that high threshold motor recruitment, it's that cross-sectional area, it's that rate of force development. So it's not just about how strong the muscle, it's about how quick the muscle can develop that force. And then we talked about some of that neural inhibition. We make sure we don't overlook that aspect as well. And the ability to time the contraction for peak force, which is really important on that sort of huge high speed running and then the multiple changes of direction. Okay. So how do we stimulate adaptive response? So again, I think back to the sort of S&C sort of physiology, we need to, stimulus must be greater than the athlete's habitual activity, so acute and chronic. So that means that's the sort of the infamous sort of 3 sets of 10 from physio. If we're giving the athlete 3 sets of 10 with a 8 kilo sort of dumbbell on a single leg sort of RDL, we shouldn't be expecting the tissue to adapt. And then the stimulus must target specific physiological response. So I touched on it before, we've got this magnitude and rate. So magnitude is how strong can we get that, and then rate is how quick can we get that to develop, how quick can we get that contraction. So if we're trying to get hypertrophy within a muscle, there's 2 things which are going to create that. We either need to put it under a heavy load or we need to fatigue the muscle. And that's going to cause high threshold muscle recruitment. It's going to cause hormone responses at a cellular level. And that mechanotransduction, sort of those activities, will then cause hypertrophy. If we don't hit either a heavy enough load or put the muscle under fatigue, the muscle's not going to adapt. So that's something we need to make sure we're always checking and challenging ourselves, that if we're giving rehabilitation, are we causing enough of stimulus to change the cellular level? I think it's really easy that we undercook that because we don't want to make the athlete sore, But at some point, especially in rehab, we can do that because we can allow them to get sore. They can have an acute protective effect, and then they can go again, and then that muscle will adapt. In the season, it's really challenging to continue to have that adaptation when there's game on game, and you're going to get some of that stimulus within the games. And then on the right hand side is that rate of force development. So we could have a muscle which is really, really strong, but if we can't get the muscle to produce that rate early enough in the contraction, there's another risk of injury. So again, this is just a mind map of, so this is the question time for a little bit of silence, and then I'll carry on. So anyone willing to shout out a high magnitude exercise for the hamstring? 7 seconds is the uncomfortable silence when you move on, isn't it, I think? Yeah, so Nordics, deadlifts, good mornings. Everyone's thinking that, I don't blame you for not saying it. And then high rate of force development, what are the exercises we're going to do that? So an RDL catch, so a single leg RDL with a heavier weight where it's like a drop and a catch, I'm sure, or a Bosch catch, or sprinting, or an isometric pull where it might be isometric, but the rate of force development, because you're doing it quickly, is going to get that sort of high rate of force development. These need to come at the rehab at the right time. We don't want to do them too early, but we need to make sure that they've been ticked at some time in the rehab. Moving on quite quickly, again, these are more just slides for reference. We'll send the slides out afterwards, so I'm not going to list all this, but this gives a really nice example of top to bottom is sort of a hip dominant exercise and a knee dominant exercise, and left to right is a sort of more medial hamstring bias and a more lateral hamstring bias. So when we're talking about the injury, so again, the example I gave, which was a sort of semi-mem, sort of concentric pulling injury, which ended up being a C category, but the rehab focus had to be on concentric activities. So in the end, it was inner range knee flutters was the exercise where the athlete showed most weakness. But then there'll be another athlete, which is going to be a sprinting injury, which is muscular tendon junction of biceps, where the focus is going to be more on high speed running. It's going to be more on Nordics and tolerating that sort of high load. So when we're rehabbing, are we really thinking about the mechanism of the injury? Are we thinking about the anatomy, which we've talked about? And are we then trying to prescribe the right exercises for that athlete? We need a broad approach to make sure we've covered everything, but are we being really specific to chase the athlete's weaknesses rather than just focusing on 2 or 3 key exercises because they're the ones we prefer more? So again, another slide showing similar activations and giving you an idea of where different exercises get more sort of EMG activity. And we can see that the Nordic best bang for buck on the sort of slide there, we can see that the medial hamstring activity is over in the hundreds on this sort of EMG activity, but it's also high on the lateral. So that's why Nordics is probably one of the most popular sort of exercises, because you get more for one exercise, you're getting a high stimulation of both muscle groups. However, we can then walk around and we can find that the different stimulation patterns and different activity for different exercises. And then these last 3-4 slides, apologies, is sort of my mind map of when you're thinking about the rehabilitation of rate versus magnitude. So one of the mistakes I've made in the past is when you're handing over, I'll just go to this slide, sorry, the running aspect, and so the S&C coaches are working closely with them, and you think the athlete's got ready for the running part of the rehabilitation, and you send them out for some straight line running, and that's, you don't put any other restrictions on, and they might go into big A skips, B skips, which might at that time be too great a magnitude at too great a rate for the athlete. So my fault for not being really specific with the S&C, handing over that sort of to the rehab phase of where the athlete's out. So we'll just go back, sorry. So again, in the gym, we're going through our progression. So if we're talking about a high rate compared to a really low magnitude, it would be overspeed training on the Alter G. So the force that we're putting through the tendon will be low, but we're asking them to go really, really quickly. Hydroworks in a pool will be down that side. And then shifting over to high magnitude and low rate would be a Nordic, where they're holding onto the weight and they're going really, really slowly. High force. At that point, unless we throw them down and catch them, the rate's going to be quite low. So again, I'll share these. This is more just a mind map just to be thinking, but with your rehabilitation, are you thinking each exercise as you prescribe it, whereabouts it sits on this sort of paradigm, and then is it appropriate for that point in the rehab? Again, we talked about the sort of the neuromuscular progressions, so A skips and jumps and holds and warm-up sort of pace. And again, when we're going to those running progressions, where does it sit when we're getting to sort of change of direction, where we're increasing the magnitude as there's that deceleration force? And then early progressions of rehab. Okay, so then we're looking at return to play. How can we assess sort of rate of magnitude? And probably the easiest way to do that would be using a Nord board. So we can get that eccentric peak force. We can compare it to body weight, so we can get an accurate idea of their strength. and we can sort of have benchmarks. In the bottom right hand corner is the sort of benchmarks we've worked to, whether it's an isometric Nordic or whether it's an eccentric Nordic. So we can get that to newtons per kilo and have an idea. We've used the data across all the sort of England players in the pathway to understand what good is, what sort of competent is, and what maybe there's work on. So we're happy to share that. Looking at the graph, we can see that we get the peak, so we get that peak force, but we also get the steepness of the curve. What's that rate of force development? And we can measure that, and we can assess that, and we can make sure that before they go back into full play, we've assessed that, looking at sort of around 50, 100 and 150 milliseconds. I think return to play is a massive part of that rehab. So this graph, without going into too much detail, just gives a breakdown of a sort of session of the different components of the drill. And the green bar chart is the sort of meters per minute. So that extensive, and it's based to peak game pace. So we're looking at what did that training session reflect to a game and the peak game pace of a game. So we can see here that these drills here, the peak game pace never really got past sort of 50-60% of what the player would be expected to in a game. The darker bar chart is the sort of accels, decels, and that's based on peak game pace. So you can see in training, this session was sort of 130, 140% of the accels, decels in a game. So in this session, the player was getting loads and loads of game pace, over game pace, change of direction drills, but there wasn't really an extensive period in there. So when we're rehabilitating, are we making sure that the rehabilitation sessions is a replication of the game? And when our players go back into full training, are we making sure that their exposure in training is replicating what they're going to get at the weekend? And this is an example for someone who's come back from a hamstring going into this session. They may need topping up with some more extensive work because they're not getting the stimulus they need, which they're going to need at the weekend in the game. And in brief summary, comprehensive daily monitoring. So we looked at the Aspetar guidelines, which are really easy to follow. They've got lots of evidence behind them. You can pick 3 or 4 of them on a daily basis and making sure that's the first thing that goes in your notes every day to look at monitoring that progress. Was yesterday's session too much? Was it too little? And we can then regress or progress the athletes. Have a comprehensive hamstring loading strategy. So those mind maps of rate and magnitude for in the gym, on the pitch, late stage rehab, are we thinking about that as we're prescribing them to make sure that it's right for that athlete on that day? And have we ticked off everything before they go back into full training? Early introduction into that running and high speed running, because we know that the high speed running is probably going to be the best exercise for a hamstring, but at the right time with the right dosage, and periodizing that. And early integration to position specific work. Know the demands of that position. A centre half does at least half the distance of high speed running than a fullback does. So if suddenly you've got an athlete who goes from centre half to playing fullback, which is quite common, that's a completely different position, and you have to understand that. And especially if they're coming back from rehab and suddenly changing position. And then just that last extensive return to play criteria. Be really pragmatic. We all know that you're not going to tick every single box and they're going to go back into play, but have that risk versus consequence with the coaches of understanding where they are and that rehab doesn't finish when they go back into play, and there's probably still another 3-4 weeks for them to carry on with that. And that's everything.
Okay. I think, Neil, any other questions come in online?
Nothing online yet.
No. Okay. Okay. Well, I think so that's the end of all the hamstrings injuries presentations, and we will now hand over to Andy, who'll give a quick few words on NIP and the facilities.
We'll be very quick.
Yeah,
right.
And also
not the food out there. So.
Yeah, and also just to let everybody else know, so the session is being recorded, and we will share a link out to this session so you can all sort of see it again remotely and enjoy it twice over.
One other quick thing as well, just to echo what we said last time about trying to build a community which is open, it's honest, it's non-judgmental. If anyone's got any cases you want to discuss now, feel free. Or if in advance of our next meeting, which will be in January, there's any complex cases you just want to bounce off anybody here or us all as a group, just email Manny ahead of time so you can get any slides or whatever, and then feel free to present, because that's certainly a culture we want to start building in the area as well.
Yeah, so for those online, in case you couldn't hear Neil from the corner of the room, so we're just saying, you know, if there are any particular cases that you'd like to discuss, then please feel free to share with us. And indeed, if there's any other topics that people would like to cover, then just feel free to get in touch and say, actually, please can we cover this? I think this would be useful, and we'd be more than happy to do that as well. Okay, sorry, over to you, Andy.
Good. Another fantastic session, I think, from the boys. So yeah, another round of applause for them, I think. Obviously, we're going to develop these over the coming months and hopefully years. Obviously, you guys forefront to that. So as I said, if you've got anything that you want to bring to the sessions, feel free. I recognise a few of the faces. I know a few of the guys have been here before, but those that haven't, obviously fantastic facilities we've got here at all levels. Yes, the football clinic have access to them, but it doesn't mean you can only come if you visit the football clinic. You can come outside of that as well. And I'm open now if anyone wants to come and have a look, a little bit of a tour, see what we've got on site. Yeah, so if you do, it'll be a quick one, so you can get your food afterwards. I've also got Vicky here as well. She's our VIP liaison, so she's the ones that look after, the clubs, the teams, you guys. So if you have got anything you want to get booked in, Vicky's your contact for that. She get you booked in, look after yours. Yeah, we will send details out on the mailing list when Molly sends CPD certificates out. Is that all right? Brilliant, good.
Yeah, thank you, Andy. And so I think that brings us to the end. So all that's left to say is thank you very much for attending, especially everybody online as well. And we'll let you know when we're ready with the next session. As Neil said, it's very likely to be January in the new year. So we'll be in touch. Thank you very much, everybody.